Good evening to you all, and welcome to this NAFLD Summit 2020. Um, we are fortunate to have a very eminent panel of speakers this evening who are going to address us. The format of this uh, educational or academic activity is very simple. We will have a series of 3 talks which are related to non-alcoholic fatty liver disease. The 3 very eminent speakers who have joined us today are Professor Anil Arora from Delhi, Professor P.N. Rao from Hyderabad, and Professor L. Venkatakrishnan from Coimbatore. To chair this session, we have a very eminent hepatologist, very senior hepatologist, Professor Abraham Koshi from VPS Lakeshore Hospital, and he'll be chairing the first 3 talks. Following that, we will have an interactive session where we have another session, another panel, which of 4 very eminent panelists who will be introduced subsequently. And we hope to have a lot of interaction in that. We have purposely tried to avoid a lot of reference in the interactive session to the medical management. We are actually planning to have a closer look at the general management of non-alcoholic fatty liver disease. Of course, we'll be more than pleased to take up any questions related to the medicines. So I hope you enjoy this webinar, which is brought to you by Sun Solaris. And with these few words, I hand over the proceedings to Professor Abraham Koshi. Over to you, Professor Abraham Koshi.
Unmute, Dr. Koshi. Unmute.
We have 3 talks, as Dr. G.N. Ramesh has mentioned. The first talk will be by Professor Anil Arora. He will speak on pathobiology of bile acids, metabolism, and FXR agonists. Professor Anil Arora is Senior Consultant and Director, Institute of Liver Gastroenterology, Pancreas Biliary Sciences, Gangaram Hospital, New Delhi. Over to Professor Anil Arora.
Thank you, Professor Koshi. It is a pleasure to be with you today to discuss about a common problem of non-alcoholic fatty liver disease. The topic which has been allotted to me is pathobiology of the bile acid metabolism. Are my slides visible? Can you see my slides?
Yes. Yes.
Okay. Yeah. What I'm going to talk to you briefly today is what are bile salts, how are they synthesized, what functions do they play in the body, and what is the effect of the gut on bile acids and vice versa. In fact, bile acids are the excretory pathways of the cholesterol. In the diet, only 5% of the cholesterol is ingested. Rest 95% of the cholesterol is synthesized in the liver. So out of the total 100% of the cholesterol, which is either taken by the diet or synthesized by the liver, has to be excreted and disposed of by 3 mechanisms. That is, it can be converted into a bile acid, vitamin D, or steroids. In fact, 1/3 of the cholesterol in the body is disposed of by its conversion into the bile acids. There are 2 basic mechanisms by which the cholesterol forms bile acid. So one of them is called a classical pathway and second is an alternative pathway. The basic difference between the 2 is that in classic pathway, you use a 7-hydroxylation of the cholesterol molecule, whereas in alternative pathway, you use a 25, 24, and 26 type of hydroxylation of the cholesterol pathway. In fact, given the choice, whole of the cholesterol will form this primary bile acid called cholic acid. But through the alternative pathway, when CYP71B is a cytochrome enzyme, it converts the C4, the intermediate of the 7-hydroxylation, into a substance called chenodeoxycholic acid. In fact, 80% of the all primary bile acids, that is cholic acid and chenodeoxycholic acid, they come from the classical pathway, whereas 20% of the manufactured or synthesized bile acid in the body comes from the alternative pathway. So both these primary bile acids, that is cholic acid and chenodeoxycholic acid, which is Ca and CDCA, have to be converted from the acids into the bile salts. And after the bile salts have been formed, we should remember that this is an unconjugated bile acid. Unconjugated bile acid is a weak acid. It is not charged and hence is permeable for the membranes. That means it can easily enter into any cell and cause damage within the intracellular region. So something needs to be done to convert this unionized, membrane permeable, unconjugated bile acid into a non-permeable ionized acid. And there are three ways of doing it. One is through amidation, second is through glucuronidation, and third is the sulfonation. The major way of converting an unconjugated to a conjugated bile acid is through amidation using a taurine and glycine pathway. So what happens is both primary bile acids, that is cholic acid and chenodeoxycholic acid, can be converted into glycine and taurine conjugates as has been shown. So what happens is that you have converted a unconjugated bile acid into a conjugated bile acid. Now it becomes a strong acid. It is ionized at physiological pH and hence it is not permeable into the membrane. Biggest advantages of this glucuronization and conjugation is that it is completely ionized at physiological pH. It's increased solubility at the acidic pH of the small intestines. It is resistant to calcium precipitation and hence large amount of these bile salts are available in the gut lumen for the absorption of the fat and the fat soluble vitamins. So this is the incoming this is the incoming bile acid which come into the circulation. So part of the bile acid which is either produced from the cholesterol or which is reabsorbed from the gut is excreted into the biliary canaliculi using the various mechanisms which I am going to show. So what body does is whatever cholesterol is formed in the body, as I said, most of it is produced on the conversion of the cholesterol, which is the excretory pathway for the bile acids. So the bile acids which are produced in the hepatocytes are excreted through a number of different transporters. So these transporters are different transporters at the level of the bile canaliculi, which excrete cholesterol, bile acid, bilirubin, and phospholipids. With that, you have bile which is produced in the biliary canaliculi, and this bile then goes out into the intrahepatic biliary system. From there, it comes via the biliary canaliculi down into the gallbladder. So you have a gallbladder which is full of bile. In fact, 92% of the bile is only water. 6% is made of the bile salt. Other components are cholesterol, phospholipids, and secretory IgA. So what is the role of this bile which is produced in the body? So liver keeps on producing bile in the body and it keeps storing it in the gallbladder. As you start eating your food goes into the stomach, which stimulates the release of the acid, and once acid goes into the duodenum, the L cells of the duodenum secrete a hormone called cholecystokinin. This hormone causes contraction of the gallbladder and it quickly moves the conjugated bile acids, which, as I told you, are pretty water soluble now. They have a good surface, they have good volume to take care of the incoming lipids. So large amount of the bile acids which are of conjugated variety come into the lumen after you start eating your food. So this is the advantage of having a conjugated bile acid. It has two different components. It has a straight, non-polar, hydrophobic membranous lipid, and then you have other side of the same molecule which is kinked, which is hydrophilic and which has membrane disruptor properties. So this is the empathetic molecule. So a molecule is called empathetic when it has both hydrophilic and hydrophobic component. Biggest advantage is it gives you an excellent surface for the fat globules to be broken down into small fat droplets. Mind you, when you eat butter, you are eating a large amount of the fat which is condensed into compact form. It has to be broken down into small pieces, which is done very efficiently by this emulsification by this amphithetic fatty acids. So large amount of the fat is broken down into smaller components, and these smaller components of the fatty acid, bile acid, and the cholesterol, they form something called micelles in the intestinal lumen. So you have large fat droplets, which with the help of enzymes in the intestinal lumen like lipase are broken down into small pieces called micelles. And this micelles, they have basically a structure which has three components. It has bile acids, it has phospholipid, it has cholesterol. So what is the fate of this micelle in the intestinal lumen? The monoglycerides and diglycerides released from the micelles are absorbed into the enterocytes. Cholesterol is directly absorbed into the intestinal lumen. The bile acid which is released from it goes out into the distal ileum, where it is reabsorbed for circulation into the enterohepatic circulation. Whereas the monoglycerides and the cholesterol are again re-esterified in the intestinal lumen with the help of apoproteins to be moved out into the as chylomicrons into the circulation to be given to the body as a source of fat. What happens to the bile acids in the intestinal lumen? As I showed you, the conjugated bile salts in the proximal bowel are actively reabsorbed through this apical sodium bile salt transporter into the enterocytes. Small part of the bile acid is also deconjugated by this bile salt hydrolase, and this becomes deconjugated bile acid. Small part of the deconjugated bile acid is also absorbed into the enterocyte without the help of active transporter. But the major chunk of the deconjugated bile acids, it comes into the large intestine, into cecum, where you have another enzyme which causes dehydroxylation of this deconjugated bile salts. And these are then absorbed into the colonocyte through this active receptor called apical sodium bile transporter. Whereas 5% of the bile salts are not reabsorbed and lost into the feces. So the primary bile acids, that is cholic acid and chenodeoxycholic acid, are converted by the bacteria into deconjugated. They are first deconjugated, and then with 7-dehydroxylation, they are converted into secondary bile acid called deoxycholic acid and lithocholic acid. Now, this is the scale of hydrophobicity and hydrophilicity. Unconjugated bile acids are most unphysiological, that they are most hydrophobic. So hence they will be absorbed quickly into the membranes and cause injury. Whereas UDCA is the most hydrophilic, that is most friendly for the body. CDAC is next, and that is the way we grade the hydrophobicity index of the various bile acids. Now, let's see what happens to the bile acid which are absorbed into the gut. Now, the bile acids which come into the conjugated bile acid which are absorbed from the gut lumen into the enterocytes, they go and stimulate this nuclear receptor in the enterocyte called FXR, farnesoid receptors. What these receptors do is they produce a substance called intestinal bile acid binding protein, which help in the migration of this conjugated bile salt from the apical membrane into the lumen of the gut to the basal membrane. From there, they go into the portal circulation, and from their portal circulation, they enter the portal venous system. And from the portal venous system, through these transporter called sodium taurocolate protein receptors, they get entry into the hepatocytes again. And in the hepatocytes, the incoming conjugated bile acids as well as the fresh bile acid which come into the hepatocyte from the synthesis from cholesterol get back into the circulation. So that is the way you have a enterohepatic circulation in which 4 to 12 times a day, this whole circulation continues unabatedly, and only 5% of the bile salts are lost in the stools. So this is what is happening. You have we have a conjugated bile acid which comes back into the circulation. So this is an enterohepatic circulation in which you have a total pool of 3 grams of bile salts in the body, of which 95% is reabsorbed in enterohepatic circulation, 0.5% is lost in the stools daily, and 0.5% is daily made in the body, in the liver from the cholesterol. In addition, the enterohepatic circulation is also dependent on so many other factors like gut microbiota, liver, uh, uh, the barrier function of the liver, inflammation in the liver, and other components which are confounding factors for the action of the bile acid within the blood. The total amount of the bile which is present in the bile salts, 85 to 90% is present in the intestines alone of the total enterohepatic circulation. Liver at given point of time has only 1% of the bile acid. Rest is moving in the intestines. And the major bile acids which are present in the bile pool include cholic acid and chenodeoxycholic acid. What are the functions of the bile? Why should we be knowing about it? It helps in digestion and absorption of not only the fat, but the fat soluble vitamins. But more important than that, we have recently realized that these are also the signaling molecule for three major issues. They are important in the glucose, lipid, and energy metabolism. They are important in maintaining the integrity and the immune modulation of the gut. In addition, they are important in looking after the immune status of the gut. How do they do it? Very simple to understand. There are two types of receptors in the gut. You have the nucleus receptor as well as the cytoplasmic receptors. Now, the nuclear receptors, for which bile acids are the ligand, they help in bile acid, fatty acid, lipid, and glucose metabolism. Whereas the cytoplasmic receptors in the enterocyte, they are important in the energy metabolism, in the maintaining the gut immunity and the glucose homeostasis. Let's see how it happens. Again, coming back to the gut lumen, as the small intestine has conjugated bile acids, cholic acid and chenodeoxycholic acid, they go and stimulate the nucleus, where you have a supranuclear receptor called FXR receptor, which leads to production of a large amount of intestinal bile acid binding protein, which helps in transport of the conjugated bile acid from the apical layer of the intestines to the basal layer, where this molecule of conjugated bile acid can be exported out into the portal vein. In addition, at the same time, see, this is the conjugated bile acid which is going into the liver. Similarly, it is also stimulating, FXR stimulation is producing a substance called FGF19, which migrates into the portal vein, causes contraction of the gallbladder, and is important in controlling the mechanism of contraction of the gallbladder during feeding. In addition, we have another receptor when, as I told you, the secondary bile acids are absorbed into the colon through this membrane receptor called TGR5 receptor, which leads to stimulation. The bile acids are ligand for these receptors, which leads to stimulation of cyclic AMP, which produces a substance called GLP-1, which moves into the portal circulation and is important in stimulation of the secretion of the insulin from the pancreas. So the FGF19, which is secreted from the enterocyte, has two functions. The conjugated bile acid, which is absorbed into the portal circulation, they are absorbed into the circulation. They go into the hepatocytes, stimulate FXR receptors in the nucleus, and produce a inhibitory enzyme which prevents the synthesis of bile acid from the cholesterol by suppressing the rate limiting enzyme in the bile acid synthesis. Similarly, the FGF, which is stimulated by FXR agonist, it goes again into the hepatocytes, produces another inhibitory substance called CYP1 inhibitor through this JNK mechanism, leading to the suppression of the bile acid. So the bile acid absorption through the action of the FXR is leading to decreased synthesis of the bile acids. In addition, once you have stimulation of the bile acid ligand and the nuclear receptor called FXR, FXR stimulation will lead to increased excretion of the bile into the biliary canaliculi. At multiple points of entry, it is also preventing the reabsorption of the bile into the enterocyte. So what FXR stimulation is doing is, it is leading to the movement of the bile away from the liver. It is preventing its uptake, and it is increasing the release of the bile into the bile canaliculi. So how does it do it? This is the FXR receptor. So this is the ligand binding region. This is a DNA binding region. So once the bile acid, which is a ligand for this FXR receptor in the nucleus, it can either produce genes which will stimulate particular enzyme synthesis or suppress the other enzyme synthesis. So it can either be suppressing some enzymes or causing stimulation or production of more enzymes. Classical example is once you have a bile acid which binds to FXR receptor, it leads to suppression of the gene which produces cholesterol. So the major function of the FXR is to suppress the synthesis of the bile acid from the cholesterol. So these are the various types of agents which are available as molecular mimicking agents of the CDCA. Look at the various composition. There are various forms. There are different type of helices. Since it is a complex structure, so depending on which helical structure you are talking of, you may have different actions of the FXR. Let's see what happens. If you give FXR, in addition to the different structure of the bile mechanism which I have shown you, it increases the expression of the VLDL receptor, it increases beta oxidation, it increases lipase sensitive lipase activity, and decreases the de novo synthesis of lipids. So overall, FXR stimulation leads to reduction of the VLDL. But at the same time, it has harmful effects. What it does is, because you are not producing cholesterol now from acetyl-CoA, so where does cholesterol go? So cholesterol gets accumulated in the body. In addition, FXR stimulation leads to reduction of the LDL receptor uptake of the receptors at the level of the blood into the hepatocytes. So in the end, three things are happening. You are increasing the production of the cholesterol, you are decreasing the uptake of the LDL cholesterol into the blood. So what is happening is, as a effect of FXR stimulation, you are increasing the blood level, which is a bad thing for hepatologists. And finally, it also has a bad effect on HDL. HDL should be high in the blood. But if you stimulate FXR through this drug called obeticholic acid, you suppress the formation of A1 protein, apoprotein 1, which is important for the movement of the cholesterol with apo1 protein out of the liver. Since if A1 is suppressed, you cannot have excretion of the cholesterol out into the circulation. So HDL is not coming out. In addition, it is also stimulating scavenger receptor B1 receptors in the hepatocyte, which lead to increased uptake of HDL. So more HDL is being taken into the hepatocyte and less HDL is going out, resulting in decreased HDL in the body. So this all is happening because of the multitude of the action which are present. So the HDL is, less HDL is coming out into the blood and more HDL is getting back into the hepatocytes, ultimately resulting in decreased HDL in the blood. So a stimulation of the bile acid mechanism by the FXR leads to increase of number of factors which will increase in the lipid production, increase in the cholesterol production, and decrease in the bile acids. So at the same time, both things are happening with FXR stimulation. You have beneficial effect of decreasing triglycerides and you have a harmful effects of increasing LDL and decreasing HDL. In addition, FXR receptors also have an effect on the insulin and glucose metabolism by increasing the insulin sensitivity and decreasing the glucose. And they also at the level of the gut have a tendency to maintain the gut integrity by increasing antibacterial defense and decreasing the pro-inflammatory cytokines in the blood. Second receptor which is present to the bile acid in the intestine is a nuclear receptor. It is a cytoplasmic receptor called TGR5 receptor. And once you have bile acid which bind to this receptor, you have activation of plethora of mechanism. It increases T3 level, leading to energy expenditure. It causes increased stimulation of GLP, leading to increased insulin release, and it also has anti-atherogenic effect. So it is a very good effect for hepatologists. You are losing weight, you are stimulating insulin sensitivity, you are decreasing the blood level. But the problem is, same TGR receptor also has a receptor in the dorsal horn of the ganglia, in addition to the neuronal endings. So which leads to stimulation and the increased activity going into the brain to tell you that there is something pruritogenemic in the blood. So stimulation of the TGR5 receptor in the dorsal ganglia is responsible for causing pruritus, which is an important component of the large number of hepatic diseases in the day-to-day practice. Whereas stimulation of TGR5 alone decreases weight, increases insulin secretion, decreases inflammation. All of these are useful effects for us. So what does FXR stimulation do? It decreases HDL, which is bad for us. It increases LDL, which is bad for us. It causes pruritus, which is bad for us. All of these have been occurring because of the stimulation of FXR receptors and stimulation of the TGR5 receptor. It is because the molecule is so complex, depending upon which helical is going to be active at a given point of time, a particular enzyme function will get stimulated. So this is a quinodeoxycholic acid, which is nothing but a 6-ethyl derivative of quinodeoxycholic acid. So this is CDCA, which is the primary bile acid, and this is the 6-ethyl quinodeoxycholic acid, which is called obeticholic acid. So obeticholic acid, once you stimulate, since it stimulates the FXR receptors in the nucleus of the cell, it affects the bile acid metabolism, it affects the lipid metabolism, it affects the carbohydrate metabolism, as well as the metabolism of inflammatory substances and the antifibrotic substances. So just because of the presence of FXR receptors in the gut as well as in the liver, you are producing a plethora of action, which can be in the form of decreased gluconeogenesis, decreased lipogenesis, anti-inflammatory action, and increased energy expenditure. So to summarize, bile acids have multiple roles in addition to digestion. They are important substances in the metabolism of the fat and the fat-soluble vitamins. They have important functions in the intestinal tract and liver for the metabolism of glucose and lipids. They mainly act through two major receptors, the nuclear receptor called FXR receptor and a cytoplasmic receptor called TGR5 receptor. The bile acid receptor modulate functions including bile acid homeostasis, glucose homeostasis, energy homeostasis, and lipid metabolism. In addition, they are important for maintaining the integrity of the gut mucosa through the immunomodulation. Finally, however, since they have a unique structure of multiple helix present in their structure, they will have unique and pleiotropic effects. Some of them may be undesirable and some of them may not be of liking to us as gastroenterologists and hepatologists. I am sure with some of the undesirable effects like increased LDL, decreased HDL, and pruritus can be done away if you tend to modify one of the helical structures, which can come with the knowledge of the basic science. With that, I'll end up my presentation and hand it over back to the moderators.
Thank you, Dr. Arora. That was an excellent talk. In great depth and yet relatively simple. Some of it may be a little difficult to completely follow, but an excellent talk. Thank you very much. The questions, I suppose, will be asked at the end of the whole session. So we will go on to the next talk, which will be by Professor L. Venkatakrishnan on the management of NAFLD, the unmet needs. So we will be coming to more clinical discussion here. And Professor Venkatakrishnan is Senior Consultant and Head of Department Gastroenterology and Hepatology at the PSG Hospital, Coimbatore. Over to Dr. Venkatakrishnan.
Can you see the slides, sir? Can you see the slides? Oh.
Yes.
Thank you, Professor Abraham Koshi. Thank you, Gian. Thank you, Charles, for having invited me to this talk. This talk is on NAFLD, what are the unmet needs. These are more of my random thoughts of what are the real unmet needs in starting from prevalence of NAFLD to the management. This is a cartoon which shows that without too much of notice, we have found that the NAFLD has become the most common cause of cirrhosis. And this cartoon comes from the Western USA, where you find 30% of the cirrhosis is due to NAFLD. And if you combine the 10% of cryptogenic cirrhosis, nearly 40% of these patients are due to NAFLD. In another study in gastroenterology, we found that NASH was probably the third in the list for compensated and decompensated cirrhosis, showing thereby that NASH has become one of the core issues in cirrhosis of liver. And even in HCC, we found that next to HCV and ALD, the NASH is probably the most common cause of HCC. And with a good treatment outcomes with HCC, we might find that NASH is probably becoming the more common cause of HCC in the world. If you look at the prevalence and NAFLD fibrosis in general population for people who are more than 45 years, we do not have too many studies either, and do we have any data to pursue the prevalence of NAFLD or NAFLD fibrosis in general population. This is a study from Netherlands which used fibroscan and ultrasound for the general population over than 45 years, or people who are more than 45 years, and found that 35.5% of people had non-alcoholic fatty liver disease, out of which 27% had purely NAFLD without any other causes like alcohol, drugs, or viruses. If they estimated for fibrosis, they found the NAFLD fibrosis was there in 2.3% in the general population. So this leads us to a question that in a patients who are more than 45 years, age, male sex, smoking, metabolic syndrome, steatosis, and diabetes may, without alcohol, may cause a liver stiffness of more than 8 kilopascals. And if you combine diabetes and steatosis, nearly 18% of the general population can have NASH as a problem, including if they have insulin resistance and diabetes, and if there is steatosis, 18% of these patients can have fibrosis. If you want to really estimate the prevalence, the challenges are that most of the data has come from tertiary centers. In tertiary centers, most of the patients who got NAFLD get referred, and then most of these patients get biopsies done. And when you estimate that in a tertiary center, it is about 100% of them will have non-alcoholic fatty liver disease because of referral bias. Most of these patients get biopsied, and when they get biopsied, about nearly 33 to 50% will have NASH. And among them, another 20 to 25% will have advanced fibrosis or cirrhosis, and 10 to 15% of these patients with cirrhosis. Can this be extrapolated to general population? If you give these figures to general population, it will be very scary. But according to Zubair's paper in hepatology, it is generally estimated that it is 25% will be NAFLD, probably 10% of this will be NASH, that is about 2.5% of general population will have NASH, and about 0.25 to 0.4% of total general population may have advanced fibrosis or cirrhosis. So we are still not very sure that we still have a large unmet need about the estimation of the prevalence of NASH in the general population. And if you screen for fibrosis, nearly if you use a fibro test, a biomarker, where you may have about 2.8% of people may have fibrosis. And if you use a fibroscan, about 7.5% may have fibrosis, and close to about 1% may have cirrhosis. The other important problem is that we have prevalence of obesity and overweight by age, and we will find the most important point here is that obesity and overweight has been increasing in the children and young adolescents, both in the developed countries and developing countries, both in the men and women. What does it indicate? What does it indicate? There is an increasing prevalence of obesity and overweight in the pediatric population and adolescents. Thereby, there is a huge unmet need of diagnosing the pediatric NAFLD and treatment. As the guidelines say, pediatric NAFLD has no drug being indicated to treat pediatric NAFLD, and and the pediatric NAFLD is driven by multiple factors, including genetic analysis. So why is the pediatric NAFLD should should be looked into, because there are two papers which shows that overweight in late adolescence will predict severe development of severe liver disease in later life. At present, we are probably looking at severe liver disease due to NASH at the age beyond 50, 60 or 70. But this study shows with emerging pediatric NAFLD or overweight in late adolescence, maybe you are preponing the severe liver disease much into 5th decade or 6th decade because of this follow-up. And the second time it has been shown that when your body mass index in childhood and adult risk of body mass index is elevated in childhood, there is an adult risk of primary liver cancer at much earlier age than what is estimated. So the problem here is with the increasing overweight, both in the developed and developing countries, both in men and women, and in the children and in the young adolescents, we may be looking at a very severe disease much earlier in life and increasing incidence of liver cell cancer. So this is something which we need to look into it, this thing. At this point of time, the AASLD and EASL guidelines do not give us any drug which can be used in pediatric NAFLD. This exactly the other thing was shown by beautifully by Giulio Marchesini. When patients have got obesity at a younger age, the liver disease related comes out much earlier in life due to cirrhosis. And you can see here, this can be manipulated by genes, it can be manipulated by hostile, but if your childhood and adolescence obesity is there, your liver related death is much, much early in life. So this again shows you that we need to look into NAFLD in the general population as well as in the young adolescents and pediatric groups. When to think about NASH? The metabolic syndrome is not only looked up by hepatologists, it's looked upon by cardiologists, it's looked upon by endocrinologists, it's looked up by diabetologists. So when you should think of NASH? Whenever you find there is a steatosis, we need to think about NASH. But steatosis is not always seen by the hepatologist. You have a diabetologist, you have a cardiologist, you have the primary care physicians looking after diabetes, dyslipidemia, and coronary artery disease. And they should be communicated about the BMI, the waist, the arterial hypertension, glycemia, triglyceride, all the metabolic risk factors. And it should be communicated to them that this metabolic risk factors can lead on to steatosis. And all the more, it is important that altered LFT in these patients should make them aware about the possibility of steatosis and non-alcoholic steatohepatitis. Because if patients have got these metabolic risk factors and patients develop NASH with altered LFT, the cardiovascular mortality is much higher than in patients who have got NAFLD. The problem here is majority of the people with diabetologists and cardiologists do not really recognize the presence of steatosis or altered LFT when they are treating patients with diabetes, dyslipidemia, or coronary artery disease. So NAFLD becomes a highly under-recognized disease. And in this particular study, it has been shown that when all the patients with metabolic syndrome were looked in different clinics, they were looked in by endocrinologists, diabetologists, primary care physicians, and by the cardiologists, it has been found, and when they looked at through these case sheets, all their case sheets, they found that only 40% had recognition of ALT increase, only 20% of patients have been diagnosed to have NAFLD or NASH, only 15% were advised lifestyle modification, only 10% of patients went in for a hepatologic consultation. A huge 60.6% of patients were not detected to have NAFLD and were linked to care. So the magnitude of NAFLD becomes a highly under-recognized disease, which is a huge unmet need in detecting NAFLD and linking them to care. If you look at this particular study, which has been seen in a department of diabetology, if patients have got no diabetes, if you look at them, they die of alcohol liver disease, and the second is non-alcoholic fatty liver disease. But if the patients have got type 2 diabetes, the liver-related mortality is because of non-alcoholic fatty liver disease, then followed by alcohol liver disease. It just shows that when you have diabetes, dyslipidemia or metabolic syndrome, non-alcoholic fatty liver disease can be one of those major liver-related deaths or mortality. And here also you can see patients with diabetes can have an increase of 3.36% of hepatocellular carcinoma in patients with diabetes, whereas the percentage of alcohol liver disease, autoimmune hemochromatosis is very, very low. So this is again a huge unmet need where we need to counsel our other colleagues to look for NAFLD or NASH in patients who present to them with metabolic syndrome. So based on this, the EASL first initially said, what could be the position statement? Should we screen a general population? They said there's no screening of the general population, but the recommendation is that there should be a case finding of advanced NASH in patients who are either have insulin resistance or metabolic syndrome. And the other problem is if patients have chronic liver disease, we should also screen for metabolic risk factors, insulin resistant and steatosis. Even it is recommended that even if the patients have got alcohol liver disease or hepatitis C or hepatitis B, it is better that we look for these metabolic factors because their progression is much higher. And whenever a patient is undergoing a bariatric surgery, cholecystectomy with a metabolic syndrome, it is probably inclined to do a liver biopsy. In 2016, it has been shown there is a big difference between AASLD and EASL, that EASL recommends that all patients with NAFLD screening for diabetes is mandatory, and in all patients with T2 diabetes, the presence of NAFLD should be looked out irrespective of liver enzyme level. I'll tell you why it is in my subsequent slides. But this is a difference with AASLD, who in 2018 said that there is no need for a general screening of population NAFLD because there are no drugs which are really approved for treatment of these subset of populations. So the EASL gives algorithm to all the other specialists who look after patients with metabolic syndrome, and they say that if patients have got a metabolic syndrome, they should do liver function test and look for ultrasound steatosis present. If the steatosis is absent, LFT is normal, they follow up 3 to 5 years. If the LFT is abnormal, they are straight away go to specialist referrals. What do the specialists refer? They are not going to give drugs, but the specialists will look for other causes of chronic liver disease. If the steatosis is present and LFT is normal, serum fibrosis markers. You have markers which may not be ideal, but at least FIB4 and NASH activity index is looked after, and they are asked to look if it's a low risk or medium risk. If there's a medium risk, this specialist referral has to go on, and low risk, they should follow it up. If we can do this by all the other colleagues who include cardiologists, diabetologists, or an endocrinologist, we might be able to detect more patients with NAFLD and NASH in the population. The other thing which we are really worried is you have a non-alcoholic fatty liver disease and you have patients who have got steatosis and you have patients who got steatohepatitis. We know that some of these patients who have steatosis may have no or minimal fibrosis. And you have patients who have got steatohepatitis. And we know that steatohepatitis is the driver of the progression of the disease, going right from F1, F2, F3, and go to cirrhosis. And once they progress rapidly. But at the same time, we should remember that 40% of patients with steatosis may not progress, 20% of patients may go to steatohepatitis, and another 20% will go on to cirrhosis. But do we know or do we have any biomarkers? These patients are being biopsied and found to have very minimal inflammation. Do we know that how many of these patients can go to steatohepatitis? We don't have a real data to say. on how many of these patients go on to steatosis. When do you look for liver biopsy? What is your surveillance of these patients who have got minimal fibrosis or no inflammation that go to steatohepatitis? And we don't know whether they remain in this group or they move on to this group. So this is a huge group of subset of population where we are not able to look whether they are going into steatohepatitis or not. Should we surveillance every year? Do we have guidelines to say that we should do LFT every 6 months? Do we have a paired biopsy? But this is a study which came from McPherson and J. Pies in Journal of Hepatology in a small group where 25 patients who had initial biopsy were only at steatosis. 8 of them went on to ballooning degeneration. And this ballooning degeneration people, about 5 of them went into bridging fibrosis, and so they went into steatohepatitis. And this follow-up biopsy was done in a group of 3 to 4.5 years. So the follow-up was in between 3 to 4.5 years. But do you think all the patients will go on 4.5 years? No. Anywhere, the follow-up studies have shown a large gap. Patients may go up in 4.5 years, or they may take 17 years, as we've seen in McPherson studies, that they progress to steatohepatitis and then go for a bridging fibrosis. So we do not know, when you look at patients in NAFLD who has got a simple steatosis, whether they can go on to, when do they go on to steatohepatitis, when do they develop fibrosis, and we don't have guidelines how to go about surveilling them. The other problem, so what is the current view? You can have steatosis, you can have a mild fibrosis. Do you have any biomarkers or any other markers to say that they will go for a high progression? No, we don't have anything. But if a patient has got a metabolic syndrome, say he is diabetic, dyslipidemic, has active increased ALT, or if he has got dyslipidemia, there is a chance that they may go on to progression. They can go on to significant fibrosis or advanced fibrosis. In one particular study, they've shown that sometimes in 8% of patients with NAFLD can go straight to advanced fibrosis without going into steatohepatitis. That means there is 8% of NAFLD patients can go on to say. And when you get cirrhosis, of course, 7% of patients are to go to HCC. But we should also think the biggest problem in NASH is that NASH with bile can go to HCC, and NAFLD can also develop HCC without fibrosis. We don't have biomarkers. We don't have any data to say which of these patients develop HCC or which of these patients develop HCC. And we also know that 8% of NAFLD can go on straight to develop fibrosis. So this is another thing. So this is a study which came from Brunt, who had 270 NAFLD patients with a minimal inflammation and liver biopsy 4 years, but it is a huge gap. Liver biopsy was done from 1 to 17.3 years apart. 16% progress to bridging fibrosis, and the only indicators they found was the patient has got diabetes, metabolic syndrome, ALT, and there's a HOMA score is elevated. They can progress to this. They can progress to NAFLD. So it is also shown that NASH can have severe hepatic and systemic disease, and if patients go from NAFLD to NASH, you can have more marked CV lesions, more severe metabolic abnormalities. At the same time, we do not know how many of these patients with NASH will have a cardiometabolic mortality, and we do not know how many of these patients develop extrahepatic malignancy. So this also, we don't have data to say how many of them develop extrahepatic malignancy. So regarding the drug development, you need to control the disease progression. You need drugs which can have for insulin resistance. You need drugs which can act on adipose dissection. You need weight loss and metabolic improvement. You need drugs which can reduce lipotoxic precursors, reduce liver inflammation, block fibrinogenesis, and all of this will together produce histological improvement. We have problems with the lifestyle management because it has been found that a single physician counseling will not be able to get the patient motivated for a lifestyle modification or a weight loss. It has been looked that it becomes a multidisciplinary approach, and that becomes a huge problem in practice. You need your physician you need a exercise therapist, you need a nutritionist, and you need a psychologist to give you behavioral cognitive therapy to keep on having a weight loss. It is imperative that patient has a weight loss which is to be there for the rest of his life. We need a lot of, and it is very difficult to get a single drug which can look at all these issues and produce histological improvement. Though there are a lot of drugs which are in the pipeline, we don't have any drug which has been approved for NASH. And we also know for the NASH treatment, the only approved drug is for when you have NASH with F2 or more than F2 fibrosis. So do we have drugs which can prevent progression from NAFLD, steatosis, steatohepatitis? We still don't have a recommendation, nor do we have any regulatory mechanisms which could help us to develop drugs on this particular. So you need to look at metabolic dysfunction, fibrosis, and inflammatory cellular injury for drugs to prevent cirrhosis and end-stage liver disease. So what are the challenge of treating cirrhotic patients? If you have developed drugs, the question is, does these drugs help us in treating when the patients become cirrhotic? What happens when a NASH patient becomes cirrhotic? One, the steatohepatitis is absent. Insulin resistance becomes multifactorial because patients lose weight, they become sarcopenic, your insulin resistance becomes multifactorial. There is fibrosis and architectural changes beyond reversibility. And you have other trigger mechanisms which trigger decomp, like portal hypertension, bacterial translocation, and circulatory shrink. Does the drugs which are in pipeline will have the same effect on cirrhosis? We do not know. And there's a huge unmet need that drugs which are being treated for treatment of patients who are in NASH and F2 fibrosis may not have the same effect on cirrhotic patients. They may not be able to trigger portal hypertension. They will not be able to. We don't know whether they can really prevent bacterial translocation. But there is a study where an FR agonist do reduce intestinal inflammation and bacterial translocation, and FR agonists have shown reduced fibrinogens, sinusoidal vasodilation, improvement in endothelial function, reduction in bacterial. You can see that the interleukin 6, the TNF alpha, everything coming down once you use this. Effects are listed. So we do not, my random thoughts about the unmet needs are, we are still not very sure about what is the prevalence of severe NASH in general population. All the estimates have come from a tertiary referral center. The real prevalence estimates needs to be done because we don't have guidelines whether all the prevalence have to be estimated in general population. Still, the disease awareness and screening issues are not proper because metabolic syndrome, people with metabolism are treated by many physicians and they don't screen for NAFLD. And we do not know how many of what is the subset of patients, or do we have any predicting factors, patients who go from steatosis to advanced NASH. And once they go to advanced NASH, who are the patients at risk of progression? And when you have endpoints for trials for drugs, we need to know whether drugs can be extrapolated to treat if the patients have become cirrhotic. And of course, when the patients have become cirrhotic, you have other problems where the drugs can act on this. So I think that's my last slide. Thank you very much.
Thank you, Dr. Venkatakrishnan, for that overview of the unmet needs in NASH and NAFLD. Since we will have questions at the end, we will move on to the next speaker. The next speaker is Professor P.N. Rao, who will speak on NAFLD and diabetes, a hepatologist perspective. Professor P.N. Rao is Director of Hepatology at the Asian Institute of Gastroenterology in Hyderabad. Over to Dr. P.N. Rao.
Thank you very much. Welcome to all the people who have logged in live session and also who are going to view our presentation in the future. And I thank all the people who have been on the screen here for this opportunity. Well then, let me I thought I would speak about diabetes and what is our perspective. What is in a name? But everything is in a name. And NAFLD, and there has been a new definition has been coined, that is metabolic dysfunction associated fatty liver disease. That is making waves now, but the importance of this is that they have involved type 2 diabetes and also the BMI and a space for lean NASH and other metabolic parameters. The first few of them are also being in the International Diabetic Federation. Vipin is with us, and then who is going to give his comments about later. And HOMA-IR and then the C-reactive protein have been added on to this one. Well, then within about a month, just like a COVID, there have been so many papers have come from various people about this new terminology. And also in all the journals, Liver International, Gastroenterology, Mexican journals, about this name called MAFLD. We gastroenterologists and then hepatologists, we always bothered about a fatty liver, NASH, cirrhosis, and then HCC. We did not take much care about the CVD, cardiovascular diseases, although we knew that that leads to more mortality as compared to the liver-related deaths. On the other hand, our colleagues, endocrinologists and diabetologists, and they concentrated more on the diabetes, cardiovascular risk, and then felt that the fatty liver was only an incidental finding. But then there has been a renewed interest in the diabetologists, as you can see here, that the latest articles as late as June 2020, and there is an extreme interest in and contribution, not only interest, a contribution in NAFLD by our diabetology colleagues. You can see here, this is already been to, Dr. Venkat Krishnan has emphasized upon the malignant potential, malignancy, HCC, obesity, and then insulin resistance are the two things which are driving the force. And this Venn diagram, not to scale, of course, diabetes common, obesity common, NAFLD common, all the three are common. And therefore, what is the relationship between the diabetes and the NAFLD? It is said to be a bidirectional. Although still there is a controversy, which starts first, obesity starts first or an insulin resistance starts first. If you look at the NAFLD to type 2 diabetes, NAFLD is associated with 1.86 and in some studies, fourfold increase about chance of developing a diabetes. On the other hand, if you take a diabetes, then as already been told, the progression to NAFLD NASH increases the risk of cirrhosis and hepatocellular carcinoma. And therefore, there have been recent articles and by Dr. Kenneth QC, that is, he is the very well-known diabetologist, endocrinologist, from NASH to diabetes and diabetes to NASH. Well, this is an interesting concept. Now, we must have a crosstalk, diabetologist and hepatologist and then gastroenterologist. And this is called the 2018 twin cycle. And simply what it means is that if you have an excess carbohydrate taken over years, that is obesity, excess carbs stored in the liver fat, therefore you develop a fatty liver, and the fat is exported from the liver to the pancreas, and increased fat deposited around the insulin producing beta cells of the pancreas, and progressive diminished the beta cell function and death of the beta cells, and decrease insulin production and causing the increased blood glucose level after fasting. There's a postprandial, and ultimate result is glucose. So the liver cycle and the pancreatic cycle are two cycles coined now. I've always been thinking earlier, we are all using NAFLD, but why the pancreas? Many times we get a report that fatty pancreas. Everybody says, no, it's likely obese and therefore is a fatty and fat pancreas. And not much of an attention has been focused on this, although we've been saying, why not NAFLD? Now it has come, this article, as you can see that, This is called non-alcoholic fatty pancreatic disease. That is, the fat is not a sitting duck. It does cause an inflammation. And this cycle, we know that is the hepatocyte cycle is there, but there has been beta cells also suffer from similar. In fact, stellate cells are also there here, just like we have in the liver. And this results in intracellular triglyceride accumulation, which results in the beta cell function death, which is, of course, added upon by the adipocytokines, and also the and the insulin secretion decreases, and beta cells, and then there is a diminished beta cell mass. This is a changing concept, of course, not for the diabetologists, for us, for the people. The type 2 diabetes, the importance of the previously it was thought to be only obesity, insulin resistance. Now the beta cell mass decrease and decreased insulin secretion are now being focused more and more. As you can see here that the progressive reduction in the beta cell mass and total absence in type 1 DM, of course, we are not speaking about that, but in type 2 diabetes, there has been a progressive reduction from normal glycemia to diabetes. This is a very, very interesting concept by Dr. Kenneth Cusey, appeared in JHAP in 2019. We've always been wondering about the lean NASH. And this is a composite diagram, a cartoon. You can see here that normal glycemic, no NAFLD, insulin sensitivity is good, that means there is no resistance. And gradually over time, what happens is that is still a non-diabetic, NAFLD sets in, still a lean, not an obese person, and we have known earlier that in the lean, there is insulin resistance. Okay, and therefore insulin sensitivity coming down, that means that there is insulin resistance increasing. Progressively, as I already told you, because of the glucose and then lipotoxicity, insulin secretion peaks, but it is ineffective, that insulin resistance is there. Afterwards, it comes down, then beta cell failure, then the total insulin resistance, and therefore, they appear to be phases as per this new concept, but this has to be still be validated. But this is, I find that this is a very, very, very interesting, which is clubbing NAFLD and a diabetes in a unique way. And then already been shown that those people who have, and there is the cumulative probability of a developing cirrhosis, be it an alcoholic liver disease or a non-alcoholic liver disease, in diabetes, it is higher as compared to the non-diabetes. And also in the right, so lower panel, even the hepatocellular carcinoma, also in cirrhotics, 60% versus 41, and HCC 27 plus 10%, the cumulative 3-year median follow-up period in diabetics, whether it's underlying disease alcoholic or it is a non-alcoholic. Well, then just see here, this is diabetes, and this is no diabetes, and then no obesity. That is a reference value 1. Suppose if somebody is no diabetes, but obesity, yes, and the chances of developing malignancy is 1.13, a slight increase. But on the other hand, just see the other one. Diabetes, yes, obesity, no, and the chance of developing is 4.38 folds more as compared to the reference value. Sometimes people come to us with HCC, long-standing diabetes. They're not obese people, but yet they have a malignancy. And this is the one. And on the other hand, if somebody is a diabetic and obesity, his chances are almost 5-fold. This concept is very important to understand, because when people come to us with the HCC, they say, sir, I don't have a diabetes, I don't have a hepatitis B, hepatitis C, I don't take alcohol. How is that I got a hepatocellular carcinoma? Remember, long-standing diabetes, not only for HCC, it is an underlying driving force for all carcinomas here. As you can see here, that liver is about 2.5, and except for the prostate, the other carcinomas are also, diabetes is the driving force. Well, then this is a combination of the diabetes pathogenesis, the diabetes, and then NAFLD. We know that the lipotoxicity, I'm not going to speak too much on this, Just glucotoxicity is the one which is coming up new nowadays, that glucose is as bad as a lipid accumulation in various cells, whether it is a hepatocyte or whether it's a beta cell. And I would refer you to this International Liver International by Dr. Kenneth QC, very latest, 2020. What is the potential mechanism by which the glucose may play a role in the progression of non-alcoholic steatohepatitis? We've always been wondering about the lipids, de novo lipogenesis, but glucose is also as bad. And this has been, Dr. Venkat Krishnan has already spoken about this, about the screening recommendations by the various groups, EASL and then ASLD. As you can see here that systematic screening has not been advised by anyone, but screening in the higher risk group have been advised by the EASL, as already been told, and also Asia Pacific guidelines. And ASLD is still mum on this particular issue. I think perhaps the next guidelines or update will be, it may be mentioned. And the modalities, as you can see here, that ultrasonography. And therefore, a step forward in the field of diabetes, the 2009 American Diabetic Association clearly have mentioned that patients with the diabetes and elevated aminotransferases or a fatty liver in the ultrasound or not end or a fatty liver should be evaluated for presence of NASH and liver fibrosis. And therefore, because our guidelines, they're a little bit vague about who should be screened, the American Diabetic Association has taken a leap and their clear guidelines have been given to them. And this has been, indeed after this helped raise awareness among the primary care physicians and also diabetologists to actively participate in the management of the NASH. And also, not only that, you see the last sentence, in the same way as a diabetic retinopathy, the importance given to the fat in the liver by the diabetologists now that they look forward to see, just as they screen and then take care of retinopathy and nephropathies and neuropathies. And that is now the more and more involvement and also contribution to NASH by our diabetology colleagues. Well then, what is the treatment? Weight loss. Both diabetologists and also we advocate weight loss, and we know that weight loss of more than 10% is being shown by 2 paid biopsies in a large number to reversal of fibrosis. But crux is that how many people can achieve 10% of the weight? Hardly 10 to 15%. Well, this is another article by an endocrinologist, Dr. Taylor from Newcastle upon Tyne, where they have got a very good metabolic unit, and say that 10 kilos, 10 kg, of course they didn't say about the percentage here, 10 kg results in normalization of ectopic fat within the liver and the pancreas. And even in the pancreas also, if you reduce your weight, the fat is going to disappear. But more importantly, they've taken the diabetics here, and the weight loss has been there, and responders who have responded non-diabetic HbA1c and responders, and these are non-responders. But look here, liver fat fails in both. Pancreatic fat also fails in both. But glucose-stimulated acute insulin secretion returns only in the responders. That means that, what it means that beta cells, which is degenerating, they are getting activated again. So these people have come to the concept that weight loss is not just simply a physical phenomenon, but what happens in the inside the pancreas is very important, that it prevents the beta cell degeneration and also increases the insulin. We have known already that a weight loss causes that less of insulin being taken for the patients when they lose the weight. And this is the proof of that concept. Very interesting concept indeed. Well, then what are the drugs which we have? We have all these drugs, diabetic drugs, where as a hepatologist and gastroenterologist, we are not very, very familiar with the combinations of the recent drugs here. But nevertheless, the drugs which are important to us or as we know that we are of course familiar with the thiazolidinones, that is the pioglitazone, and these are the places where these drugs are active. Now let us see now. Metformin is there. The mechanism is there on the left-hand side of the panel, and the effects on the NASH. There are two things which we have to remember. A, NASH is there. How many anti-diabetics can be used to reduce, to get the effect of histological effect? Another is, patient has got a very frequent diabetes and also NASH. What anti-diabetic drugs will be useful in this particular situation? Let us see what happens here. I'm not going to talk about the NASH and the treatment here, but predominantly concentrate on NASH and a diabetic, right? And if you see here that metformin, we know very well that metformin is good. Metformin prevents malignancy and it causes the reduction of the weight. But if someone has got a NASH, metformin has not been found to be useful when histology has been repeated. Well, then taking cue from our PIVINS trial, that pioglitazone has helped, but it did not reach the statistical significance that this study done in 2010, and the diabetologists have taken over, and that was, PIVINS was in non-diabetics, and therefore they wanted to see the role of a pioglitazone in people with the pre-diabetes and then diabetes, and they applied the same kind of a primary endpoints and then secondary endpoints here. As you can see here, that is very encouraging that pioglitazone has achieved its very primary endpoint and also resolution of the NASH, and also some amount of an improvement in the fibrosis also has been seen in a small percentage, right? And this is one. Next, what they wanted to see by the same endocrinology colleagues is that vitamin E has been found to be. Then why not club both vitamin E and then pioglitazone? And this is a proof of concept study where vitamin E 400 BID and pioglitazone 45 has been given, and the primary endpoint has been achieved here. But this is a very small study, a proof of concept study, but vitamin E alone has not significantly changed any primary histological outcome. So pioglitazone does help, and then adding vitamin E also may help, but that combination will still be validated in a larger trials. And if you know us, we all know that the pioglitazone is the only anti-diabetic drug which has been given some kind of a green signal. It may be used in patients with diabetes with a biopsy-proven NASH. All the rest of the anti-diabetic drugs in a patient with a NASH but without any diabetes still do not have much of a role. Well, then let us go through GLP-1RA and then DPP inhibitors, and let us see here that this is again supposed to be a landmark study. This is of course phase 2 study only. The lean study, GLP-1 receptor liraglutide again has found favor, but this dose is a diabetic dose but not a weight losing dose, and weight loss has been there, ALT has decreased here. And the other drug, SGLT2 inhibitor, that is empagliflozin, and also Cana also have been tried, and they have shown some kind of a primary, reaching the primary endpoint and the secondary endpoints also. So then see here that pioglitazone has certainly improved in histology in many of the cases. Weight has increased here, that is the disadvantage here. Whereas when you come to GLP-1 receptor agonist, the liraglutide, the body weight has been decreasing here, that the intrahepatic triglyceride, there has been an improvement in the histology. When you come to sitagliptin, that is the gliptins, weight has been neutral, because that's our very important thing, and intrahepatic, but no studies, histology has not changed. So sitagliptin in patients with the NASH and with the diabetes is not useful. On the other hand, the glyphosomes have been found to be useful because they reduce the weight. I'll finish in about 1 minute. And then what is important in these people is that which are the drugs which are going to cause a weight gain, which are the drugs which will cause a reduced weight. Insulin, sulfonylureas, and the pioglitazone, the weight gain. Whereas the metformin decreases, which is the backbone of the treatment here, and DPP-4 inhibitors are the neutral ones, but the one which reduce are definitely GLP-1 RA and SGLT inhibitors, right? And summarizing these, metformin, body fat decreases, body weight decreases, they are very inexpensive first-line drugs. For thiazolidinones, evidence for the NASH exists, but on the contrary, weight gain, edema, cardiac failure, and these things are there. Just one minute. And GLP-1, again, the GLP-1 and SGLT are the ones which are useful, and the gliptins are not useful in these patients. So what do we do? The one which has been advocated by our endocrinology colleagues is that first is, of course, metformin. Then if you do not achieve your goal, then if you're obese person, you can use a GLP-1 RA, that is liraglutide, but it has to be given as an injection. If the weight is not much, the BMI is Indians is different, I don't have to say that, then you can consider pioglitazone. Still not, then you can go for other drugs like insulin, right? And in people with an advanced liver disease, we have got a caution for the child C cirrhosis. The child A, there is no problem, but nevertheless, one has to use some kind of a caution even if you are using the metformin and insulin, because hypoglycemia is very common. So one practical point of a glycemic control in the liver disease is that because of the hypersplenism reducing the red cell span, and artificially it lowers the A1C, we think that our diabetes control, it may not have been controlled. And it's an integrated approach is here. This is one of the recent 2020 algorithm by our hepatologist, involving the FIB score and the NASH scores here is that. And therefore, ladies and gentlemen, the NAFLD is associated with the 2 to 3 fold increase in the risk of developing diabetes. And patients with the diabetes have got an increased fibrosis in the end-stage liver disease and HCC also. And lastly, among all the pharmacological agents which are available to us, the thiazolidine is good, but one has to be careful about the side effects which are mentioned. Metformin is the backbone anyhow. Pioglitazone, GLP-1 RA, these are the ones which are promising the management of NAFLD and then NASH. And thank you very much for your attention.
Thank you, Dr. Rao, for that excellent talk, emphasizing the bidirectional nature of the relationship between diabetes and NAFLD. We will have questions at the end of the panel discussion. So I will hand over to Dr. G.N. Ramesh to initiate the panel discussion. Over to Dr. G.N. Ramesh.
Thank you very much, Professor Abraham Koshi. And thank you very much for the three speakers. I know you're there to be a part of the panel. We have got a very enriched panel. We have got Professor D. Krishnadas, who's the HOD, head of the department at Medical College Hospital, Trivandrum. We have got Raj Kumar Wadhwa, who's the director of gastroenterology and endoscopy, Apollo BGS Hospital, Mysore. We have a very senior person, Professor Varghese Thomas, who's a professor and HOD at Malabar Medical College and Research Center, Calicut. And we have got an endocrinologist, a very young, budding endocrinologist, Dr. Vipin from Aster MedCity. And I have my colleague, Charles Panikal, also from Aster MedCity. And we together will negotiate the close to 20 questions that I've already noted down, which have come in from the chat box, as well as the other questions that I had actually outlined. So I will set the ball rolling by first of all asking Raj Kumar Wadhwa. Let us start off with the basics. Now, whenever there is non-alcoholic fatty liver disease, whenever there is NASH, in one word we say do exercise. Now, what is the form of exercise that is best recommended for people with non-alcoholic fatty liver disease? Over to you, Raj Kumar Wadhwa.
Thank you, Jian, Um, yes, I think we should understand that probably one of the first recommendation you tell the patient is control your diet and do exercise. But what kind of exercise and how do you go about doing it? More importantly, once you start doing that exercise, how do you maintain it? All this is important because probably that forms the basis of the treatment what we are going to give. We all know that majority of the patients are obese, they are diabetic, and aerobic exercises are difficult for them. They'll come with an answer saying that they have a joint pain, they can't walk for a long. In that situation, I think it's the muscle building exercises or strengthening exercises which should be recommended. There has been a study to look for whether you do aerobics or whether you do a muscle building exercises. Both they definitely decrease the steatosis. But if you take the muscle building exercises, then probably you decrease the energy and you will have more motivation in people, those who have a coronary artery disease or those who have physical limitations in doing this. Um, how do we extrapolate it? We can tell to the patients to do simple exercises um, by doing cycling at home if you are keen on doing aerobics or making it more interesting. Can make an interesting exercises, but those who can't, simple acceptable exercises to the body weight and the conditioning of the patients on lifting and conditioning the muscles will be the appropriate options in these circumstances.
Okay, you mentioned about obese uh, diabetics with non-alcoholic fatty liver disease. Now, I would put the next question to Krishnadas. We know that a proportion of patients are lean. I mean, this question was sent to us by Dr. Shifa Ramnath. How best would you advise a patient who is a non-diabetic, non-obese, non-alcoholic fatty liver disease? Krishnadas, please.
Yeah, thank you, Ramesh. Actually, we have metabolically healthy obesity, metabolically unhealthy obesity, and now we have got the lean people who are actually metabolically unhealthy. So, how do you define that? And why is it that some people who are lean, if when you go by the BMI, but still they are metabolically not healthy? It is these patients that most probably develop fatty liver disease. So, what is the change in them that make them metabolically unhealthy? And Dr. Priyan Rao just rushed to one slide when there was a couple of people with probably with the same BMI, but with a lot of different uh, metabolic factors. I think you just skip that slide.
Yeah, that's right.
So even though if you have the same BMI that is less than 23, the same person will be having a lot of different factors like they could have a higher body fat. The distribution of the body fat. The body fat is best if you have. I mean, there is good body fat and not so good body fat. The visceral fat as well as the epicardial fat is metabolically very active, and that is not very good for you. So, but the BMI may be the same. And to start off with, when you are about 30 years, your BMI may have been 21. Then it slightly creeps up to 22 and 23. So there is a rise in BMI, there is a rise in weight, which is not metabolically good for you. That could be one factor that can result in fatty liver. Then it is your food intake. You may have a higher cholesterol intake, you may have a higher fructose intake. Fructose is ubiquitous in our diet. Even if you take sugar, it contains fructose. Most pastries contain fructose because fructose is quite cheap and is much more sweeter than sugar, so it is used in all the bakery foods. Where fructose is known to produce fatty liver. And how to treat that? Maybe NFL, I mean, fatty liver in a lean person may not have the same outcome as in an obese person. By outcome I mean not only the liver outcome but the cardiovascular outcome may also be not that bad as in a metabolically unhealthy obese person. But still you have to treat it. And if the person does not have significant, you go for a VCT. If the VCT does not show, I'm talking only of the liver part. If the VCT does not show significant fibrosis, the best thing would be to prevent further gain in weight, to get him to do a bit of exercise, as has already been mentioned by Dr. Wadhwa, both aerobic and muscle building exercise. Because it is not only the adipocyte, but the muscle that is also very important. And people who have fatty liver, who are lean, but are metabolically unhealthy, may have a bit of sarcopenia when you compare with lean, healthy people. So building of muscle spends up, gets you to spend a lot of fat and brings down your ugly fat. And as such, there is no indication for treatment of NASH or NASH in people who are lean.
So pharmacotherapy
may not be possible.
Varghese, we always keep talking about weight loss, and I've often seen patients getting very irritated. Why is this doctor keeping on saying about weight loss? P.N. Rao said 10% is what is good, but most people are not able to achieve that. In your practice, how do you make it achievable for the patient, weight loss?
Yeah, this is one of the most difficult thing to do, because we all say it is lifestyle modification is the most important aspect when we manage NAFLD or MAFLD of late. Okay, now that includes diet as well as exercise. Dr. Vadhav has told about the exercise, and one must approximately do around 240 minutes of exercise per week, both aerobic and anaerobic. Agreed. Regarding diet, the moment we say diet to the patients, they are confused. We doctors ourselves are not very sure of diet, because we have never been taught in great detail about the nutritional aspects of various types of food we eat in different parts of the country. So we are at a loss to explain things properly. First, they should understand what is the calorie, how much calories they take, how much per gram will lead to that, and they should be given an idea that it is actually they are going to take a healthy, nutritious diet rather than a diet imposed upon them. So we should actually change the terminology from dieting to healthy, nutritious diet. There should be a positive, some sort of thing. Second thing, all this time we were talking about fat. There are a lot of changes which has occurred in the nutrition aspect, which most of the doctors are unaware of. And most of us are actually technically not capable of telling the details of a good diet to the patient. We tell something very cursorily, and they will go and try to implement that fail. I think a good dietary program has to be there, and the patient should be referred to that dietary program. It has been found out by studies that patient referred to a good dietary program had good results compared to those who have been just told in the office by the doctor, physician or gastroenterologist or endocrinologist. So I would suggest that the patient should be part of, it should understand everything what we are going to do. How much craving is there, what is the craving due to, when you eat, what all things you feel satisfied, what all should you avoid. And so it's actually speciality by itself. And I would say, we are totally ignorant about it, most of us. And that is why we fail. And to add to that, I had a patient who I gave a lecture for 15 minutes, and he came back and told me, doctor, is it before food or after food I have to eat? That means my routine food. Understand? So that is the understanding about diet by most of the patients. So we have to give a clear-cut idea. We have to be very clear. We have to be very clear. Then we should entrust somebody who is quite capable of doing this, to giving good dietary advice. That is what I say. And that is why we are failing. That's why we are failing.
Okay, so I think the dietitian should be an integral part of the team that treats a patient with non-alcoholic fatty liver disease.
Yes,
Vipin, when listening to P.N. Rao, for a moment I thought that he had moved from hepatology to from hepatology to diabetology, and it was indeed quite a masterly presentation. Vipin, whenever I've interacted with Vipin, he said these days weight loss, a lot of patients are coming and they've got good results with anti-diabetic drugs, and I was quite surprised. Vipin, your experience with the newer generation of anti-diabetic drugs with respect to weight loss, and do you think, a very provocative question, may not be agreed by all, that all patients with non-alcoholic steatohepatitis should be treated by a diabetologist?
First of all, thank you, P.N. Rao sir, for the wonderful presentation, because it was a very informative talk, and many recent articles which I have gone through in 1 or 2 days for preparing to answer all these questions have been covered in your presentation. It gave us a new idea regarding how to manage diabetes as well as liver disease. So whenever in my clinic or in my practice or our practice, when we consider an anti-diabetic agent to be prescribed to a patient, The first thing that comes to our mind is definitely the efficacy of drug in terms of reducing the blood sugar. First. Second thing, we should not have hypoglycemia. Then as the guidelines evolved over a period of 4 to 5 years, we have to ensure that if the patient is having obesity or overweight, we should have weight loss, and it should be having some CV benefit if it is possible, renal benefit if it is possible, and now we should have a liver benefit, which is also possible. If it should be there, it should be given to the patient. And the second thing we should mind is there any contraindication for prescribing this anti-diabetic medication to the given patient, considering the liver status as well? So child C, child B or child C, whether we can give this agent as well. So if we consider an obese patient, as Rao sir was mentioning, with type 2 diabetes mellitus, with elevated SGOT and SGPT. First of all, as everybody was discussing, lifestyle therapy as well as exercise is the thing, and the gold standard metformin comes as next, unless the patient is having a very advanced liver disease. Then the most efficacious drug to reduce the weight as well as the improving the liver enzyme in clinical practice as well is the GLP-1 receptor agonist. So GLP-1 receptor agonist, everybody is having difficulty in digesting that because it is an injectable thing. And the liraglutide we are having as a subcutaneous injection daily. Dulaglutide and semaglutide, it is having weekly injections. And now we are coming with oral semaglutide also. It is actually a daily preparation or a weekly preparation that we can have an oral agent which is also acting as GLP-1 analog. In all the randomized control trials as well as in the clinical experience, the weight loss with respect to GLP-1 receptor agonist is between 4 to 6 kg if you choose the patients wisely. And we should explain that this drug is acting by this mechanism. You may be having some little bit of nausea and vomiting, but it will suppress your appetite, and the weight loss is seen over a period of 3 to 6 months. And this weight loss will be seen as long as you continue the medication. So that is the thing. And second class of drug, as sir was mentioning, is it is SGLT2 inhibitor. We are having canagliflozin, empagliflozin, and dapagliflozin. The weight loss that we can achieve with these agents is around 3 to 5 kg. As compared to GLP-1 receptor agonist, these weight loss happens very quickly over a period of 1 to 2 months time. Then it plateaus off because the mechanism of SGLT2 inhibitor, we know it is glycosuria, because we are losing around 50 to 75 grams of glucose in urine. That will produce that much, around 150 to 200 kilocalories we will be losing without doing any exercise. So the effect is very quickly. But the glycemic control and weight loss happens, and the SGLT2, the SGOT-PT improvement is also seen in some of the SGLT2 inhibitors. But the problem with both these agents, the GLP-1 analogs and SGLT2 inhibitors, both the data is like measuring the liver enzymes as well as the imaging. It's not a histopathology proven study. So it is not approved as an agent to treat NASH. But in clinical practice, it is doing the maximum benefit for the patient. And now the dapagliflozin is coming with a DEAN trial, which is having a histopathology report before and after treatment. And the SEMA-NASH study is also coming because it has been, the initial data is that it has improved the fibrosis score in chronic patients who are having diabetes and NASH. And the other drugs that we use for the treatment is dual PPR gamma alpha agonist seraglitazar. That is not mentioned in any of the guidelines because it comes from the country like India. But any patient who is having diabetes, dyslipidemia, along with SGOT-PT elevation, we can try that agent. Even though it is weight neutral, we can have some amount of improvement in that. Pioglitazone, last point, sir. Pioglitazone produces weight gain, and the dose recommended is 45 milligrams. So that drug we are not using in diabetes mellitus with NASH, sir, practically speaking.
As an extension of this question, I would just like you to ask, I'd like to ask you a very brief question.
Right,
all
sir.
These drugs are in patients who are diabetics.
Right, sir.
Would you recommend any of these drugs for non-diabetics obese?
Sir, regarding the non-diabetic obese patients with NASH or SGLT2, SGOT-PT elevation, liraglutide has been approved as an anti-obesity medication with a dose of 3 milligram per week. And it is also having a beneficial effect on the visceral fat. It reduces the visceral fat as well as improves the SGOT-PT levels in patients who are obese with liver disease. But lean patients with liver disease, none of these agents are recommended. And canagliflozin is also having a Motivist as a 300 milligram tablet. It's also being tried in obese patients without diabetes mellitus for weight loss as well.
Okay. Dr. Krishnadas, a lot has been written about coffee with relation to liver disease. And is it a myth or a reality? Do you encourage your patients to drink lots of coffee? If so, in what form?
Yeah, personally, I do encourage my patients to drink at least 4 cups of coffee a day. Why? There are a couple of big trials, not only in liver disease, but in the general population. One which came in NEJM had about 400,000 participants, and they found that coffee reduced all-cause mortality except cancer mortality. Liver disease was not included. CVA, cardiovascular mortality, everything was reduced when you take coffee. And if you take more than 3 to 4 cups of coffee, there was almost a 10% reduction in mortality. And coming to liver disease, and particularly NAFLD, it isn't found that coffee reduces the chance of developing NAFLD. Second, it reduces the chance of developing fibrosis and increase in fibrosis. Not only that, even in HCV, it has been found that it reduces fibrosis. It reduces the chance of developing HCC. And more than 4 cups of coffee a day does not actually increase your, it does not improve your health, but up to 4 cups of coffee, there is a linear relationship between amount of coffee taken and the improvement in health. What coffee? Filter coffee has been found to be better than non-filter coffee, but the filter coffee, one problem is that when it filters out some of the diterpenes like caviol and cafestol, but preserves certain other things. So filter coffee may be slightly better, and it's always better to take caffeinated coffee rather than non-caffeinated coffee. And amount of caffeine you can take in a day is about 400 milligrams. And 1 cup of coffee, that is 230 ml of 230 to 240 ml of coffee, will contain from 60 to 130 grams of 130 milligram of caffeine. So you can calculate how much coffee you can take. And whether you can add milk, I'm not very sure. There is no definite literature whether adding milk increases or decreases the utility of coffee. But one thing that is a definite no-no is sugar. Because sugar is a combination of glucose and fructose. Fructose is bad for the liver. So, and again, sugar increases the calorie intake and results in obesity. So coffee without sugar, with milk or without milk, would be my choice. And I ask the patients to drink at least 3 to 4 cups of coffee a day.
Great.
Is it a positive risk?
Wonderful. Dr. Anil Arora, there are a lot of questions on the OCA. Dr. Swapnil Kankare has asked a very point-blank question. Has OCA fulfilled an unmet need in the management of non-alcoholic fatty liver disease? Where will you position it in the algorithm as far as management is concerned? And would it still be an off-label use?
In fact, if you look at the way I have tried to look at the mechanism of action of FXR agonist, of which OCA is one of the prototypes, there is not much it does in terms of improvement in non-alcoholic fatty liver disease. See, if I see 100 cases of non-alcoholic fatty liver disease, 90 of my patients have only fatty liver disease, 3 will have NASH, 7 will have cirrhosis of the liver. So most important component, as most of the faculty members over here have stated, is lifestyle changes and reduction of the fat. So that cannot be undone by FXR agonists. So obviously it has not met the need for 90% of the patients. There is a good regenerate interim analysis recently presented by Dr. Ratzu, Dr. Rohit Lumba, Arun Sanyal, and Dr. Zubair Yunesi, in which they have shown that it does decrease fibrosis in a subgroup of the patient, which they have analyzed as an interim analysis. But as of now, FDA has not given an approval to even use it as an off-label thing. Because if you look at the pathogenesis of fatty liver disease, there are various ways how the fat gets into the liver. Major problem is insulin resistance. Because of the insulin resistance, fatty tissue and the muscle is not able to intake glucose, and they have to rely on something else. So because of insulin resistance, there is a persistent lipolysis in the fatty tissues. So increasing load onto the liver with fatty acid, with hyperinsulinemia and glucose. So liver is bombarded by three things that leads to fatty liver. So any hypothesis of development of NASH has to progress via fatty liver. And 90% of the fatty liver occurs because of insulin resistance. Whether you're obese or no obesity, it doesn't matter. You ask this question of lean NASH. There's nothing called lean NASH. Everything has to be metabolically abnormal. So they have abnormal visceral adipose tissue, they have insulin resistance, they have a problem of difficulty in getting rid of the fat from the body. So unless we tackle the basic pathogenesis, I think one single drug can never be the panacea.
Okay. Your concept of metabolically active steatohepatitis or metabolically active liver disease, Professor Abraham Koshi, are you here with us? I don't see him. Charles, I would like you to come on. I was actually quite attracted to this particular terminology of metabolically active steatohepatitis or liver disease. Do you think that we as hepatologists should forget the term NASH and embrace this terminology MASH for our future clinical use?
Good evening, sir. Thank you. See, as Professor Arora said, NAFLD or fatty liver is a component of the is due to the metabolic dysfunction of the body. So, any patient with fat in the liver and obesity, any patient with fat in the liver and diabetes, or any patient with fat in the liver and any of the components of the metabolic dysfunction, we have to make a positive diagnosis of metabolic dysfunction associated fatty liver disease. That's a new term for NAFLD. That's metabolic dysfunction associated fatty liver disease, or MAFLD. So any patient with fat in liver and obesity, any patient with fat in liver and diabetes, or any patient with fat in liver, even if they are lean, they've got any of the components of metabolic dysfunction, then we have to make a positive diagnosis of MAFLD. So the new term going forward would be MAFLD and not NAFLD.
Okay, okay. So any other comments from any of the other panelists about this new terminology of redefining non-alcoholic fatty liver disease as metabolically active liver disease or metabolically active steatohepatitis?
Yeah, Dr. Ramesh, there was a recent discussion in an international forum regarding the need for redefining. Ultimately, the consensus is that the very first definition of NAFLD is very vague. It only says non-alcoholic, and there could be 1,000 more causes of fatty liver other than alcohol. By default, it is a incomplete definition because it encompasses anything and everything on earth which can cause deposition of the fat, be it dyslipidemia, hypertension, diabetes, genetic factor causing fatty liver, or even drugs causing fatty liver. So this proposal to replace it with another terminology like MAFLD, which is equally incompetent in the sense it doesn't tell you which metabolic component, diabetes, hypertension, dyslipidemia, genetic factors, obesity, behavioral problem will have different pathogenesis. For the time being, the expert group which has proposed this definition has decided to withhold the changeover from NAFLD to MAFLD, because earlier also it was an incomplete definition, and still with MAFLD you are equally bad. So there is no point of changing over from one incomplete definition to another incomplete, because metabolic syndrome again is a vague definition. You have different components of the metabolic syndrome. All of them will have different pathogenesis, and you do not have one common goal point.
Thank
you.
Thank you.
At the moment, it is decided they are possibly not going to change over, though it look lucrative.
Yeah, P. N. Rao, you also wanted to make the same point?
No, as I said already, there has been a lot of discussion, even the published one. In the month of March itself, March and then April, there are at least 7 articles, editorials on this particular issue. People are divided, but most of the people, they say that we've been having this for so many years, NASH, and then the focus will be lost, just simply by changing from NAFLD to MAFLD. The fold, Although there are 3 people are there, that Shiv Sarim was there in this one, Rohit Lumba was there, and but still, it is not yet time to change.
Yeah, I think
what many people have felt.
I think Anil's argument is also valid, that from one incomplete definition going to another incomplete definition.
That's right, exactly.
Okay, fine. Dr. Anil, there were a couple of questions. The lipid profile that becomes altered in patients on OCA, the lower HDL levels and the high LDL levels, are they clinically relevant? Number one. If so, how do you manage them?
I think that is precisely the reason why the drug has still not been approved across the board for treatment of non-alcoholic fatty liver disease as a standalone therapy. You see, I showed you the excellent mechanism, multiple mechanism as to how OCA causes increase in LDL and decrease in the HDL by the different mechanisms. Now, on paper, it may look that you can treat increase LDL by addition of, say, statins, and decrease in the HDL you can counteract by HDL. So we pose the same question to the original authors of the study, that is Zubair Junesi, Arun Sanyal, and Rohit Lumba. They believe that it is a transient phase which settles with passage of time. But I think, let's be honest, even if it is a transient phase, and we should remember, Dr. Rao very clearly presented his data that in patient with non-alcoholic fatty liver disease up to stage of NASH, the cause of the mortality is cardiovascular, not the liver. And in that arena where the mortality is because of the cardiovascular events, reduction of LDL, reduction of HDL and increased LDL will always be problematic. So till these issues are solved, as I suggested you, I showed you the multiple agonists of the FXR. If we are able to modify their helical structures so they do not have a pleiotropic effects, that means you can have reduction of the bile acid synthesis. You can have useful effects like reduction of VLDL, but harmful effects can be taken care of by modifying the structure of the FX agonist. That will be the line of therapy rather than the currently available first generation FXR agonist. I don't think they'll be approved.
Venkat, I'll come to you with a very, very provocative statement. And this is an offshoot of what Anil just said. And point was also made earlier. The number one killer in a patient with non-alcoholic fatty liver disease is cardiovascular, not liver. Is it accepted?
Yes.
Then the question therefore arises, should all these patients be taken care of primarily by the cardiologist and the internist and not the hepatologist or the gastroenterologist? Your answer to this.
Yeah, the problem here is, as I told you, there is a big lacunae in the cardiologists and diabetologists looking out for NAFLD. And you have a subset of populations who will have a silent NAFLD. They can progress to non-alcoholic steatohepatitis. It has been clearly shown that if you have diabetes, you have dyslipidemia, you have metabolic syndrome like hypertension, or if you have insulin resistance and you are being managed by a diabetologist, they should know that these patients have to be screened for NAFLD or NASH. Because once you have a NASH along with your metabolic syndrome, even the cardiovascular mortality also increases. And they do badly and once they go into fibrosis, even though they may take anywhere between 4 years to 17 years to develop fibrosis, once they develop fibrosis, they go down rapidly. And we know once they become cirrhotic, the NASH-related cirrhosis has got a lesser survival than a patient with HBV or HCV. And patients with NASH cirrhosis with HCC have got a much poorer prognosis than other things. So what I was trying to tell you, the unmet need is everybody who is looking after a patient with a metabolic syndrome needs to know about the possibility of a NAFLD or a NASH being underlying problem, and they have to recognize it. This is what I think the EASL gave a very good algorithm, primarily for the cardiologists, primary physicians, diabetologists, and endocrinologists.
Okay. Rajkumar Wadhwa, there are two questions which I would like to give to you. One is by Dr. Vipin. He says that there are so many diets floating around which are recommended for weight loss. Do they really help, or is it just tailoring the diet according to the needs of the patient? Number one. Number two, there are lots of drugs that actually cause modest weight gain. This is from Dr. Rajesh, who's a very prominent gastroenterologist at Cochin. Like the oral contraceptives, atenolol, metoprolol, pregabalin. Would these drugs also accelerate the progression of non-alcoholic steatohepatitis?
Yes. Thank you, Gian. Coming to the first question about the diet. In the management of non-alcoholic fatty liver disease, we need to understand that diet remains the primary therapy to control the weight. Exercise gives only a modest decrease in the weight if done properly. But unfortunately, if these diets are not properly given, majority of these patients tend to gain weight back again if you give a sudden reduction in calories with the help of the diet. While it is generally believed that it is the calories in the diet which will affect how you achieve it is your choice, your taste. And that is the most important part of it, and not the nomenclature given to it. That is probably irrelevant in these situations. Now, coming to the drugs, yes, these drugs are known to cause increase in fat in the liver and are believed to have a progression, especially drugs, we give it, for example, we give acetylopram. While they are combined with the anxiety, they tend to gain weight. And then these patients are believed to have an increased progression so we have to be cautious while prescribing these drugs in those patients who already have a pre-existing NAFLD. I'm not sure, I have not come across any studies which tell that starting these drugs in a lean individual will cause fatty liver. I'm not aware of it. Maybe my other colleagues will be able to tell me that. But yes, those who have a pre-existing NAFLD can have a progression of this disease.
Any other inputs? Because this is a question to the answer to which I personally don't know much, not aware. Any other inputs from any of the other faculty members about drugs causing weight gain? Do they accelerate non-alcoholic steatohepatitis?
See, there are two queries about it. First, I fully agree with Professor Vadva that what matters in development of the fatty liver disease and subsequently NASH is the mere calories. The type of the diet does not matter. And I didn't show you the basis of pathogenesis of fatty liver disease. Ultimately, what happens is there is a leptin resistance at the level of hypothalamus. That means if you and me eat diet today, it will lead to increased glucose in the blood that releases insulin. Insulin stimulates fatty liver, fatty tissue, which reduces the leptin. Leptin goes and causes satiety in the hypothalamus. Problem with fatty liver disease is that there is a leptin resistance. The person doesn't feel satiety, and that's the reason you keep on inadvertently eating. So irrespective of the nature of the diet, what matters is calories. As Dr. Vadva said, if you are able to tone down your calories, you will have a persistent good result. That is the first thing. Secondly, definition of NAFLD includes that at the time of diagnosis, you must ensure that none of the drugs which are known to be causing fatty liver are being taken. But then once NASH develops, any drug, especially that is the reason pioglitazone is not used by most of us. So any drug which is known to aggravate fat deposition is going to be harmful. So we should always look forward to having alternatives to these.
Thank you. Varghese, two questions. One is how, it's very common to see patients whom you've recommended, whom you advised, loaded them at advice. They come back saying that, doctor, I tried everything, but I have not lost any weight. How do you handle this situation? Number one. Number two, Venkat clearly mentioned there is no role for drug therapy in pediatric NAFLD. We do get lots of them. How do you handle that situation?
The best answer will be to refer my patient to your enemy, my competitor. Because, as I have told earlier, it is agreed that there's a lot of failure in diet therapy or healthy, nutritious diet therapy. That is mostly because the doctor as well as the patient does not understand what they are aiming. We must have clear goals or targets shown to the patient. This is what we aim. See, not only the waist circumference, and the other parameters which of the metabolic syndrome, like hypertension, diabetes, dyslipidemia, including transaminase levels. So all these parameters, at least even at some point, if there is improvement, the patient is likely to follow a diet. Another thing is that we have to understand, apart from the calorie, the volume concept. The persons are used to eat certain quantity of food, and unless they eat that much quantity, they feel unsatisfied, the satisfaction level. Okay, so you must fill the food basket with things which are relatively inert and doesn't contain that much carbohydrate. And carbohydrates are the most dangerous thing. Contrary to our popular belief, we all thought fat was the most dangerous thing. No, it is carbohydrates which are the most dangerous thing. So all the diets, basically it should be low carb. It doesn't matter whether the fat is normal or high. In fact, ESL recommends that even a ketogenic diet can be given. There's no problem. So low carb, good or high protein with normal fat or high fat, that is possible. So the persons should be able to also, many people have that what is called craving, because because if you eat a carbohydrate rich meal for the breakfast or any meal for that matter, you feel hungry by 5 to 6 hours. It's very interesting to note that if you skip your breakfast, you actually won't feel hungry that much for your lunch unless you have got acid peptic disease. So patient must be also stimulated to do intermittent fasting. So they must be in fact taught all about the nutrition aspect of the food, and they must be given enough choices rather than being very strict. They must be able to pick and choose from a variety of foods which have no low nutritive value, I mean caloric value, but with other nutritive abilities. And this is beyond the comprehension of an ordinary doctor. That is why I said they should be referred to a standard weight reduction program which includes exercise as well as good dietary advice. Of course, there are empty number of people giving it all over India. And there is another thing. Most of the youngsters, especially those who are in the IT industry, are the ones who are obese and are likely to have this problem because of the very little physical activity. There are a lot of apps which have come to help them. There are a lot of apps which help them to decide the type of calorie, how much calorie they are reducing. And there are a lot of free apps, and there are a lot of other apps which actually control the exercise, and they can be linked. In fact, so they will have a sort of an objective way of assessing their own dieting, their own weight loss, etc. Otherwise, we were just telling them, and then they are doing or not doing, and then come back and then we don't find any effect. So we also have to sort of interact with them proactively, participate in their program, and refer them to appropriate good programs. That's what I think.
Thank you. Professor Anil, there's one question from Dr. Swapnil. In NASH with dyslipidemia, can we consider combining saroglitazar with OCA?
Yes. Can I just comment on the previous question with what
Yes.
Dr. Varghese was saying? Two important issues. One is biochemically, he is absolutely correct that it is only glucose and amino acids which can form fatty acids through acetyl-CoA. Fatty acids can never produce glucose. So he's absolutely right that if you eat too much of the glucose, that is worse than, because fats cannot be stored as such. Whereas glucose, if you take in excess, especially in insulin resistant, it can be diverted to lipogenesis and stored as fat. That is the first thing. Secondly, the comment on dietetics advice. You know, in a typical dietary advice, most of the time, like what happens in our center is that they'll give you a preformed proforma. Oh, this is a 1500 calories diet, do and go and get it done. I think we need to have a good nutritional counsel as a part of your own team. Ordinary kitchen diet, which will provide a prefix proforma, is a hopeless thing. So patient gets dissuaded. They'll write down already preformed items which the patient would have never heard it. So there is a difference in the basic diet in North and South India. So anybody given a fixed chart will never be of any use. You need to have dietitian as an integral part of your own team who knows what to do. That is secondly, that is very important. Secondly, the combination of saroglitazole and OCA does make sense in the sense that, you know, the saroglitazar is a PPR alpha and delta agonist. How it acts is it suppresses the formation of the lipids and it increases the beta oxidation through its effect on the PPR alpha mechanism. So theoretically, it will reduce the triglyceride, but will not do anything to the cholesterol. See what is happening. If you look at the mechanism of action of FXR, it is decreasing VLDL and triglycerides, and it is causing increase in cholesterol. Typically, saroglitazar does not change cholesterol. The combination will not be of help. Only if it is able to decrease cholesterol, it will be of help. So what is suggested in the regenerate trial is that if you have to take care of raised cholesterol on OCA, you have to use statins, not the saroglitazole.
Okay, we'll have to quickly move to the last two questions.
Dr. Rao had a comment, I think, is raising.
Yeah.
No, I just wanted to ask now, Vipin, you've been using the saroglitazole 2013 is been given. Now also, as you know, there's been approved for by Indian DCGI for our this one. And what is your take on that one?
Okay,
It's
basically,
a safe drug that we know, isn't it? Safety
Right.
of the drug is very good.
because for a diabetic, it is approved basically for the diabetic dyslipidemia.
That's
So
right.
the amount of HbA1c reduction with saroglitazole is very minimal. We can say between 0.2 to 0.4%. So it is not a powerful anti-diabetic drug. Then the amount of triglyceride level it reduces, it's wonderful. Because even if we combine a statin along with a fenofibrate with a low carb diet, even in patients with diabetes mellitus, there can be situations in which the triglyceride level alone is about 250 close to 500. In such patients, we add saroglitazole not to improve the glycemic control, but to improve the triglyceride levels. So with addition of lipaglinor or bilips, that is saroglitazole, what we have found is the diabetes, we have to take care with other medication. The triglyceride level will come down, and gradually we can cut either fenofibrate or the amount of statin that we are giving to those patients with maintaining on saroglitazole. As you were mentioning, it is a side effect free drug, and we can use in even we were using these patients who are having genetic forms of hypertriglyceridemia, or patients who had pancreatitis with hypertriglyceridemia as well. So that is our experience. Right.
P.N. Rao had mentioned about this concept about fatty pancreas. I'd like to ask Venkat, your experience, have you seen patients with fatty pancreas? And do you think that fatty pancreas will be more dangerous than a fatty liver?
I have not really seen fatty pancreas, but I've seen chronic T2 diabetic patients coming out with some sort of a echogenic pancreas in ultrasound, number one. And some people do have some elevated serum amylase, which they get worried about, but it's been described in patients with long-standing diabetes that you can get an echogenic pancreas due to a deposition of fat as well as an exocrine insufficiency. This is what is my take on this.
Anyone else?
Comment on saroglitazole?
Yeah.
There is increasing reports of fatty pancreas on CT scanning, which I have been noticing for quite some time. And there are some reports which say that fatty pancreas is also should be considered part of metabolic syndrome. There are some reports saying that.
Yeah, you see, if Dr. Ramesh, can I answer that? You see,
Yes.
the basic problem in NAFLD is insulin resistance, which nobody talks of. That is the central hallmark for which we just cannot do anything. So after that, we have a plethora of events. We have pleiotropic effects. We get NASH. We talk of CCK antagonists. We talk of cellulosarnata. We talk of ASK inhibitors. We don't talk of the basic problem. If we are able to do something to the insulin receptor so that all tissues keep on taking glucose, like muscle, fats, and the ectopic organs, then nothing will happen. And even fatty deposition is a part of insulin resistance, in which, because pancreas cannot take glucose for its normal activities, it is forced to take fat as a part of the fuel for metabolism, its normal activity. So Dr. Varghese very rightly said, it is a component of the metabolic syndrome in which the deposition of the fat in the ectopic tissues, be it the liver, the muscle, or the pancreas, which damages. So in muscle, it causes sarcopenia. In liver, it causes NASH. There is increasing evidence that excessive deposition of the fat decreases its endocrine and exocrine function. So it is equally bad. Again, the basic pathology comes back to metabolic syndrome and hyperinsulinemia because of the insulin resistance. Unless we tackle all that, downstream tackling will never be of use.
I don't think we have a drug which can really alter the insulin resistance, but only exercise is being shown to.
Absolutely, yes.
Venkat,
I think that is where we need to have the basic research. Some molecule at the level of the receptor of downward signaling.
which
That is very
probably corrects the insulin resistance.
So can we change the name to insulin resistance associated abnormalities like liver disease, etc.?
That is a factual information. Everything stems from insulin resistance. If there was no insulin resistance, there will be no NASH. We'll be sitting pretty idle at the moment.
The future terminology may be like that then.
Even in lean NASH, it is insulin resistant, which is the key.
Dr. Rao is a big man. Dr. Rao can suggest to the big authorities. They
Okay.
listen to them.
That last question. This is from Dr. Shifa. Locasirin in cirrhosis and the risk of HCC. Anyone can answer that?
You see,
Locasirin.
Yeah. What is that? Say it again, please. What is the question?
Locasirin is a drug which is used for the weight reduction.
Okay, okay. Yeah.
Sir, actually, the locasirin is no longer available for use. It has been banned by FDA because of the toxicity or side effect which was seen along with the usage of locasirin, because it was a modest anti-obesity drug which were available and it was marketed by Sun Pharma as well. So now it is not available for the use.
So we will not discuss that. I think we've handled a lot of questions, lots of information coming up, and I thought this was a discussion with a little bit of difference. I would like my colleague Charles to come in now and give his views and then finally wind up the meeting.
Thank you, sir. Good evening, all. That was, we had a fruitful discussion for the last 2 hours, and thank you all speakers and the panelists for sticking to the time. We have nearly 500 participants who have logged on. So it was a very fruitful discussion. And I'd like to, on behalf of Dr. Ramesh and myself, I would like to thank all the panelists and all the speakers for accepting our invitation and taking the time from their busy schedule to be here with us. And also I'd like to thank Sun Solaris for giving us a platform to discuss on what is new in NAFLD. Thank you all. Good evening and thank you all.
Back to Sun Solaris, and on my personal behalf, Dr. P.N. Rao, Vipin, Varghese Thomas, Rajkumar, Anil, Venkat, Krishnadas, all of you, thank you very much from the bottom of our hearts, and back to Sun Solaris, Omanakuttan.
Thank you.
Good evening to all the delegates who have spent your valuable time with us till now. And I sincerely thank Dr. P.N. sir, Anil Arora sir, and LVK sir for their excellent presentations, and Dr. Abram Kosli sir for chairing the session. And I also thank Dr. Krishnadas sir, Vadva sir, and Varghese Thomas sir, and Vipin sir for their expert comments and panel discussions. Last but not least, I'm very, very thankful to GNMS sir as well as Pinnacle sir for their entire support to design the program and supporting us in every step of this program to make it very, very successful. Thanks. Omna.
Thank you.
Yeah, thanks all, sir. I don't have nothing to tell for everybody. My sincere thanks for this wonderful program. I think it is satisfied many doctors with the good information. Thank you very much, sir.
Thank you, sir.
Thanks.
Thank you, and we'll leave. Bye. Good night.
Okay.
Have a wonderful week ahead.
Thank you, Dr. Sir. Thanks. Thanks.